I'm David Gertz, and I'm the Brandman Foundation Professor of Cardiac and Pulmonary Diseases of the Faculty of Medicine of the Hebrew University of Jerusalem. It really was indeed a great honor to be invited to deliver a talk today, just a short while ago at the 20th World Congress on Heart Disease here in Vancouver. The title of the talk that I gave this morning was what diabetes mellitus has taught us about potential treatments for small abdominal aortic aneurysms. And just by way of a few points of background, abdominal aortic aneurysm is present in about 8% of men over the age of 65, and actually as much as 12.5% or maybe even more of men between ages 74 and 85. And actually, abdominal aortic aneurysm has become the 13th leading cause of death in the Western world. The normal abdominal aorta is usually less than about 3 centimeters in maximum diameter, but when it reaches 6 to 7 centimeters, the risk for rupture, which is really the problem of this disease, is about 10 to 20%. And when the diameter expands to over 8, the risk of rupture is actually 30 to 50%. And the problem is that mortality outside of the hospital from a ruptured aneurysm is over 90%. And because of the high prevalence of abdominal aneurysm and the fact that over 50% of those who are not treated actually die from a rupture, the U.S. Preventive Services Task Force in 2005 recommended that all males age 65 to 74, whoever smoked, have a one-time ultrasound screening. And as a result of this screening, more than 80% of the diagnoses of aneurysms now are actually relatively small ones that are less than 3.5 centimeters in maximum diameter. And the increased detection of the aneurysms on one hand, and the high rate of severe complications of the currently available emergency treatments have really emphasized the need for less invasive strategies that target the pathogenic mechanisms of progression and rupture. We know that the major risk factors for aneurysm are, besides advancing age, are smoking, which is 7 times the normal. Then male sex, systolic hypertension, hypercholesterolemia, a positive family history. And all of these risk factors also are risk factors for atherosclerosis. But what may seem to be surprising is that diabetes, which like the other risk factors is a major risk factor for atherosclerotic occlusive disease, is not a risk factor for abdominal aortic aneurysm. And in fact, epidemiological studies have shown that patients with diabetes have approximately 35% fewer aneurysms than the general population. And also they have approximately 25% slower yearly progression of the aneurysms when they do have them. So why is it that in sharp contrast to hypercholesterolemia, diabetes is actually negatively associated with aneurysm? And we actually discussed these issues in a piece that we wrote in the American Journal of Cardiology in February this year, which was entitled "Contradictory Effects of Hypercholesterolemia and Diabetes Mellitus on the Progression of Abdominal Aortic Aneurysm." The answer seems to be that in hypercholesterolemia, increased infiltration of inflammatory cells favors an increased proteolytic state that breaks down the matrix proteins of the wall. But diabetes, through through the increased glycation of the protein precursors, actually facilitates matrix protein synthesis and increases covalent binding of these matrix proteins, making the wall actually much stiffer, causing it to be less prone to proteolysis and therefore decreasing the likelihood of aneurysmal dilation and rupture. In recent years, in our laboratory, we showed that low-level laser photobiomodulation, which is a technology that's used empirically widely for reducing pain, inflammation, and increasing wound healing, actually inhibits the development and progression of abdominal aortic aneurysm in a mouse model of aneurysm. And in those studies, we found that the overall mechanisms for the effect of the low-level laser, why it reduced the development and progression of aneurysms, was very similar to the mechanism by which diabetes is in some ways protective of aneurysm formation. And that we found that the low-level laser significantly upregulates collagen fibrous matrix repair of defects in the arterial wall that seem to precede aneurysm development in this mouse model. And it turns out that although the precise underlying cellular mechanisms are a bit different, reinforcement of the extracellular matrix in the aortic wall appears to be common to both of these situations, to diabetes and to the way low-level laser prevents the aneurysm in the mouse model. And so it appears that reinforcement of the protein matrix of the aortic wall appears to be an important mechanism-based target for novel treatments and technologies, just like low-level laser therapy works for the stubbornly progressing small aneurysms that are refractory to risk factor modification and that are basically destined to end up with obligatory surgical or endovascular intervention, both of which are associated with significant morbidity and frequent catastrophic consequences. So this common mechanism, the mechanism by which diabetes mellitus reduces the likelihood of aneurysm, and low-level laser, both of them reinforce the extracellular matrix of the arterial wall, rendering it less prone to aneurysmal dilatation and rupture.